Hi there, I am Dr. Precious Adadidiodu, a senior lecturer in adult nursing and an international lead for the Department of Nursing at the University of Huddersfield in the UK. I am the principal investigator for this collaborative project that seeks to develop a UK-Ghana partnership to co-develop a dementia referral care pathway for Ghana. Over the past 3 to 4 years, we've embarked on a journey of a research portfolio that sought to estimate the prevalence or the burden of dementia, especially within the Ashanti region, and also because we know that family caregivers are at the forefront of taking care of people with dementia. We also explored their lived experiences. And we didn't just end there because we are solution-focused and action-oriented. We also asked for the coping strategies for such experiences. And we know that as academics, we usually publish and they sit in journals, but that do not really make the impact as expected. So last year, with the research investment funding from the School of Human and Health Sciences, University of Huddersfield, graciously administered through the Office of Strategic Lead Research and Innovation, Professor Philip Brown, we were able to convene almost 100 people here in Kumasi, Ghana, that cut across different cadres of healthcare professionals, psychiatrists, psychologists, mental health nurses, faith leaders from all the different major faiths in Ghana. We also brought together media people were present. We also had community leaders, academics, researchers, family caregivers, people who are living with dementia, and many others.
On behalf of the Center for Aging Studies and the University of Ghana, it is my singular honor and pleasure to welcome you to the Institute of Statistical, Social and Economic Research for this landmark workshop on developing a UK-Ghana partnership to co-design a dementia care pathway for our country.
The Ministry of Health recognizes dementia as part of Ghana's broader response to non-communicable diseases. Our non-communicable disease strategy calls for stronger prevention, early detection, integrated management, and improved quality of care for chronic conditions throughout the life course.
Let me begin by commending the University of Huddersfield, KNUST, the University of Ghana, Konfanoti Teaching Hospital, and others for bringing this partnership to life. Dementia is no longer a condition we can afford to treat as a distant, foreign problem. Globally, an estimated 55 to 75 million people are living with the condition today. As Regional Director of Health, I wish to assure this gathering of the full commitment of the Director General of the service. The Regional Health Directorate stands to be part and ready to support the piloting of this framework, integrates its recommendation into our routine primary healthcare structures, and champion the policy conversations needed to secure its place within our national non-communicable disease agenda.
Your presence here reflects a shared commitment to improving the quality of care and the quality of life for older people living with dementia, as well as their well-being and the well-being of their families and caregivers. As healthcare providers, we understand that healthcare is most effective when it is person-centered, when it is compassionate, when it is delivered through collaboration. I am confident that through our collaborative expertise and commitment, today's workshop will make significant contributions towards developing a dementia care pathway that strengthens healthcare delivery and improves the lives of countless Ghanaian families. I'm excited to be part of this dementia project that has been ongoing for a while, led by Dr. Precious Dodu and his team. Last year, they were here to disseminate their findings on their research and on dementia and diabetes. This year, they are here again for us to co-design a framework for the care of people with dementia.
Issue about aging is real. And in fact, Ghana is one of the fastest growing aging population in the sub-region. Great emerging technologies, everybody's happy about it, social media, but there are advantages to westernization, right? But there's a breakdown of the extended family system. Dementia care is critical. Is the government doing something about dementia care? Religion plays a very important role. That is why we should stop calling people witches because they are old and single. Now, the problem is that when the pastor says, don't go to the hospital, just go for prayer, then it doesn't work. It hasn't worked. And so that's what they did. But when they go to the hospital and they go for prayers, there's scientific evidence people do better.
Last year, we did disseminate the findings of our study to a group of people, and based on that, we created solutions. And it was out of that we are here today. As it stands as a country, we don't have any dementia registry. We don't know how many people in Ghana have dementia, but I dare say we have a lot of people with dementia. From what I have said from the WHO data, 60% of the people with dementia live in low and middle income countries, including Ghana. 4 years ago, we got some funding from my institution, University of Huddersfield, and I want to graciously thank them for that, for their support. First of all, we set out to know what the prevalence of the burden is in the Ashanti region. This is where we did the project. And we recruited 800 people. We wanted to screen them using the Roland Universal Dementia Assessment Scale to screen them. And interestingly, we had about, in total, 23.4% when you put men and women together. The dementia risk from the people were 23.4%. Almost 1 in every 4 people we recruited were at risk of dementia. Now, as it stands as a country, we don't have any dementia policy. We don't have one yet. But we have what they call the National Aging Policy, which was about 16 years ago, which put a bit of priority on a few things. Number one, the policy talks about things like promoting well-being, active aging, and enhanced living conditions. That's the objective and goal. As part of the well-being promotion, they aim to focus on health care, social services, and economic opportunities. The other thing is active aging. They want to encourage participation in community and national development. But interestingly, we also wanted to know what factors have a role in developing or of being at risk of dementia. We found that amongst women, especially those who were of a lower age category, were less likely. In other words, lower age was more protected. The lower your age, the less likely you are to develop dementia, which is actually what we expected. So that's for females. Males, health index played a key role. Those who were from households with higher economic power were less likely. Both, one of the main factors that played a role is that those who were more formally educated were less likely to develop or be at risk of dementia. And I guess we can all think about some of the reasons. We had to speak to those who are at the forefront of taking care of these people, who are the primary caregivers. We wanted to know what their experiences are. One of the things they said to us was that they were stressed and burnt out, which is expected. Another thing is that they sacrificed their personal things and also time commitment. Some even lost their jobs or forfeited their jobs to take care of their family members. It's a big thing, you know. Others had said to us that it even affected their marriage, education, many things. Is the fact that you have a fragmented, or if that's been me being euphemistic, practically non-existent dementia referral care pathway. In other words, if you have somebody come to the lower tier healthcare facilities, either a district hospital or CHIPS compound, even if they pick it up, it will take a long time before they get to who ultimately will have to support them. And by the time this is done, the condition would have worsened. Then we wanted to know, how then do you cope with it? Because this is a problem you are living with. You can't run away from. How are you coping? So then, all these were strategies they employed to be able to cope with them. 3 to 4 years ago, we set out to do a lot of some project. Again, it was funded by the University of Huddersfield. All these projects we've done so far are internal funding from our university, and we genuinely appreciate that support, because without them, we wouldn't have been here. We brought together over 100 people, and what we did was that we brought family members, people with dementia themselves. We brought religious leaders from all the religious angles. We brought the media people. We brought academics, researchers, community leaders. We brought many other policymakers, actors together. And what we did was, first of all, we shared the findings I've just shared with you in detail to them. And then, so we did pre and post survey as well, to be able to tell before we shared the result and afterwards, has there been any improvement? And there was a massive improvement in their knowledge when it comes to dementia and dementia care. And today, you and I are here to say, based on this and our experiences, we think from now onwards, this should be the way forward. If somebody comes with dementia or signs, this is what we should follow.
The review revealed that routine screening is not existent in the primary care setting in most of the low and middle income countries. That was captured by the studies. So we know that in Ghana now we have the primary healthcare policy, which was recently passed. We also have the CHIPS compound initiative and other primary healthcare system. It's supposed to help us to detect illnesses early and be able to start treatment too early. Unfortunately, like other LMICs, we don't have that integrated yet. So it's like it's in silos. And we also realize that when it comes to the screening again, the tools that are used for the screening, they are heavily reliant on Western context. They are not really designed for our specific context. You know that the way we interpret things in Ghana and other low and middle income countries are not the same as the high income countries. After diagnosis and everything, the post-diagnostic isolation is real. That is where the issues of palliative care and then equity comes into play. We don't do that. And currently, like I said, our health insurance and the health financing regime are also not too supportive at the moment. And so this is where we are in terms of Ghana and in terms of low and middle income countries when it comes to our dementia care pathway and how things operate.
Reverend ministers are here, and you know, Christianity, we believe in miracles and prayer. So when ministers happen to see people with these symptoms, many of them believe that with the power of Jesus Christ, those people will be healed. And the other side of it is church members are accused of witchcraft. So such people mostly are not giving much attention, but rather ours is to pray for them to be healed. So I am seeing there should be a collaboration, a strong one, faith practitioners, but it will be very necessary because many people come to church. So if the ministers involved are also giving this training, until I came to this aging center, I also supported this view.
We have not been able to continue the capacity building to strengthen our primary health care to be able to do this. The guideline equips them to be able to use this for the education during the community debates, the outreaches, and all that. When they are doing their health talks and education, it has that aspect, very lengthy part on psychoeducation, and also to reduce the stigma that we've been talking about, our beliefs and all of that.
Even though you see the majority of the workforce are nurses, in our curriculum is now that we are trying to push, even from the diploma level. Gerontology used to be under public health, and then now it's on its own. And then gradually, I see that dementia is also under psychiatry, that they do it as an elective. They just go into details more. Maybe as this thing comes on, there should also be a policy to the NMC that this, because now our population is increasing. is increasing. So we should get nurses prepared to understand this group of persons so that they also get involved. Because at the training level, if you don't get it, and you say that the person should be given at the in-service level, no, you may not get it.
This is what we have. These are the interventions. But if we look at the people on the ground who are supposed to do that work, sometimes it even comes with a lot of burden. So you have an algorithm that you have to go through. The people know, but when you go to our primary healthcare facility, if you see the number of people there sitting there, people don't have time to go through all that. But interestingly, now studies are looking towards behavioral and psychological symptoms, which actually come in before the memory challenges. So sometimes the fact that somebody is having a symptom like depression, anxiety, psychosis, it may actually be a prelude to a cognitive impairment rather than like a primary psychiatric condition. So I think most of the time that's the other bits that we miss. And I think we talked about the misdiagnosis. So we may actually misdiagnose and say that they have a primary psychiatric condition. But personally, what I do is in my clinic, it doesn't matter the condition that you come in with, but I go ahead and assess for neuropsychiatric symptoms. And then if you have any of them, we follow you up for cognitive impairment.
So how do you draw the dichotomy between age-related, normal age-related forgetfulness and that which has been caused by Alzheimer's, or dementia in that regard?
That's why I'm commending the organizers of this meeting, developing a care pathway in Ghana and in the UK Ghana partnership. It's a great effort, and I also saw along the line the researches that were being done and being presented to us. Kudos to the guys who are in those departments and teams, because research was another problem when we started. There was no research, there was no prevalence rate. All the rates you can calculate, you use to calculate or to develop programs across the country. There was nothing, there was no information on dementia except Dr. Akbalu, who was then in Kintampo area, and did a small work. That's what you could see online. That was all. There was no research on this. But I congratulate the young guys who are now coming out, researchers and so on now, to feed the system so that we can develop on these things and use them to develop other programs.
Issues of stigma has to be addressed at the early ages. What are we doing? Even as a form of education, our doc from the nursing school spoke about the fact that dementia and these courses are treated even at the nursing school, especially for the psychiatric students. And those who do general nurses, only a bit is being touched on. So we could just see the huge gap of stigma that we create so you grow old with that kind of impression. And now we are telling you to unlearn all the things you learned when you were young. You were taught that anybody with forgetfulness is a witch because we are associated with it, and we don't teach the children even at that age. And so you grow before we are not telling you that no, the person might be having a problem. So even as a way of awareness creation and a form of education, I think that we should go down to the roots. How children are being taught about infection prevention, diabetes, malaria, some of these issues that affect us in our old age. And these children are the people going to take care of us. Must be aware even at the early stage. When they are living with their grandparents or their early parents, they understand their condition and not to stigmatize. I think it's a long way for us to even address the issue of stigma.
In the same policy, you see that we are proposing that MOH critically looks at embracing caregiving, formal caregiving, as a source of employment in Ghana. Once we do that, then we will be able to recognize the informal ones, because there will be a category where even if you cannot read, you can go and learn how to care for your person that needs care.
and then be certified with something small, so that in future, if NHIA and the other health finance mechanisms will open up, they'll be able to absorb and say, for your time in the house, this is what we are paying you. It happens in the US, so it can happen in Ghana too.
We have already started taking steps in improving the knowledge of our doctors in taking care of our older adults. So right from medical school, we do have a class for the medical students in their final year. We introduce them to geriatrics and we talk about dementia. And then in our family medicine residency training, we also emphasize a lot on geriatric care. And we actually have a whole module that looks at some of the subspecialties in family medicine, and geriatrics is one key subspecialty that we talk about. And so our family physicians are coming out with some basic knowledge in geriatrics and how to take care of older adults who have dementia.
Sometimes it gets very depressing and quite hopeless, because a lot of times I work at Kumfanoche. We are like the tertiary institution. So by the time they come, it's far advanced. There's not much that can be done. So I really think this is a really great program, because we want to look at the referral pathways and how we can get them to come earlier. But I also want us to be looking at how we can offer them these therapies, these services, how we can make sure it's accessible and it's affordable to them.
Dementia care is not actually integrated in our NHIS, and then you could see, you could obviously see that in the middle income or low income communities, a lot of people. I work as a psychiatric nurse, and then a lot of people who have been coming from the communities and villages suffering from dementia, and then we can't do much. Sometimes their children or relatives are not even with them. They stay alone in their communities. We give them medication or we give them treatments, guidelines, and then they are not able to follow it.
The first point of call in cases people don't understand is to go to the pastor. But how does the pastor become aware that before you attempt to diagnose things spiritually, you must know the physical dimensions as well? So for personally, if someone comes to me, what I first of all ask is, have you seen your doctor? So after the person has seen or has the knowledge to identify spiritual cases from physical cases, then the person can take it from there. But what I find challenging in our pastoral circles is that most people don't have the understanding and the knowledge to be able to handle things they don't understand. So anything we don't understand, it is prayer. Anything we don't understand is demonic. And so until we are able to get people trained to understand these realities, we may mishandle issues. And in Kumasi, I've lived here for almost 2 years. Everybody who holds a Bible, microphone, and a speaker is called a pastor.
Like the nurses, most nurses are at home doing nothing. If the government can afford it, maybe they should let them go house to house, the villages. For example, when you go to the north, they have most of the northern parts. Sorry for using them as an example. They used to tag these older women, especially, forget the men, they are witches. So I think maybe if the nurses, our community health nurses, those working currently, or a lot of nurses at home now doing nothing, maybe they can go to house or go to the information centers, the churches, the mosques, and then give them education on one, dementia. And also, if they feel their elderly women or mothers or grandparents are having this kind of behaviors, like talking, like the signs and symptoms, they should bring them to the facility. Maybe we will be able to help them, and also the insurance aspects. Now we've gone to the various places, the houses, the churches and the rest. Now they are bringing them. When they bring them, or maybe we want to treat them, now the cost, how are they going to afford it? So that one to maybe, like others they've said already, we should find a way to help them, the government, so that the price will come down, they will be able to treat them. And if we do this one, maybe we identify them earlier, even before it gets to the worst stage.
The first thing is that there is lack of knowledge, even among healthcare workers. That's the fundamental thing. It's still not in our curriculum. My recent study about medical schools and their curriculum is not there. So if the doctors themselves don't know what dementia is, what are we talking about? Who will be able to diagnose? Even when you take to the doctors, they say you should take the person home. So I think the first thing is that we should make sure every doctor, every nurse completing this, any school in Ghana, know about the care, because we have more older 60 plus than we have about neonates. And yet we do neonatology, we do pediatrics and talk about them. So it's a basic blind sight. There was a time our life expectancy were in the 40s. Now it's 68. So there has to be a renewal of mind in how we educate our health workers in the country.
When we check the Islamic view on dementia, in the Quran, the chapter of the Romans, there's a chapter named the chapter of the Romans in the Quran, verse number 55. Allah explicitly makes mention of dementia and the stages that the human being goes through in life, where Allah says, Allah will let you. It is He, Allah, who created you from the state of weakness. That is when we are infants and babies. Then from that state of weakness, there will be a stage of strength. Then Allah explicitly goes forward and mentions that after that stage of strength, that is the stage of youth, then there will be a stage of weakness and old age. That in as much as Islam also acknowledges what you term as spiritual healing, incantations, it also acknowledges getting medical remedy from professionals, seeking medical advice, and it also acknowledges dementia as an element in our society.
In order for us to live the UK's model, I was thinking about how best we can use middle-level clinicians to close the gap. Currently, you see that most dementias are being diagnosed by either a geriatrician or you have a consultant dementia specialist just like yourself, or a urologist who is coming in to probably make the diagnosis using DSM or maybe ICD-10 or something like that. But we have a lot of PAs who are in the system. There's no other program for them in terms of their specialty. Most PAs are doing public health and they don't find themselves in this other specialty. So I am thinking that for a tax shifting opportunity, it is best when you enroll persons who have trained in PA to focus on dementia or probably geriatrics or something, for them to help bridge the gap in seeing a consultant. Currently, if you want to see a consultant, you have to book. Secondly, you have to pay huge sums of money before you see a specialist, and that is actually a cost that families will not be able to afford, despite you may have the NHIS. Still, you will have a consultant who will insist that because of his or her specialty, you need to pay for it. And that is it. For the primary care level, you know that definitely when you see a GP, probably that's free for you, that it can cover. And apart from we having the physician assistants, I think Ghana College for nurses have also started their programs in psychiatry, and then you also have other programs. So if they can also enroll programs pertaining to geriatric specialty, these are the people who may be middle level clinicians who can help to close the gap, before you can reach out to a consultant. Because currently, how many consultants can we actually train, and how many of them can really see all persons with dementia? Estimating the number of people who currently have dementia, those that we have diagnosed, those that we are yet to even know.
The increasing prevalence of dementia actually places significant burden on nurses, because as this person brought the in-law in addition to other patients, and he is not really sick, but it's just because of the symptoms of the old age. That is why she is pushing for the admission. And this is going to add on to the workload of her colleagues. And so beyond the physical burden of the workload, we are also faced with the challenges in communication, because with these symptoms of dementia, it takes a lot of skills to communicate effectively with the patients. And then also managing their safety and all of that within our resource-constrained environment. And then we don't have a lot of training in geriatric and dementia care, as we've all emphasized here. And so I think that nurses need support in our training. We need a lot of encouragement. We need a lot of specialist training, so that we can also do our best. Because even if colleagues, are even adding up to this, then you can imagine people who are at home who are not even in the healthcare profession and don't understand anything about dementia.
So we need to educate the relatives, the caregivers, for them to understand what the patient is going through. And when we educate them to understand what the patient is going through, it tends to relieve the stress. Because me being the nurse assessing the patient, and I mentioned something for them to just mention it to me, if they are not able to do it, I am okay, because I know and understand the situation of that patient. So I believe that when the caregiver is also educated, for them to understand their parent or their relatives, they wouldn't be so much stressed about certain things.
The area of just the diagnosis is a problem. And I agree with Doctor when she says that our community health nurses would have a role to play. Not only them, even our MOs. So if we don't build the capacity of these staff in order to catch these symptoms and signs early, we end up with them presenting at very late stages. And as my sister rightly said, how do you differentiate between normal old age symptoms and then dementia? It's very important. So I guess we need to build the capacity of staff, and that is where I will really lay my point.
And I believe that one of the things that perhaps would help is the kind of aggressive carpet bombing advocacy that we experienced some time back, where if it was HIV, you switch on the TV, the radio, anything, there's something on it to bring it to your mind, so that people already have some idea about it, even in the homes. You see, especially in an era where you switch on your radio and there's a supplement for everything. You live near an information center, there's a supplement for everything. And so people try to find their own way around issues before they can finally get to a place where somebody can put a finger on what is happening. Doc made the point about how the curriculum of training doesn't prepare too many people to be able to identify what they are even encountering. I think it is time for that retraining and retooling to begin, not just for the technical people, but so that when somebody's mom or dad at home begins to show certain signs and symptoms, there's enough of an index of suspicion for the person to know that, okay, if I don't know what is happening, I need to find out somebody who knows what is happening. And then I think the final point that I want to make is that this is a good beginning, frank conversations on what has been missing all along. But I think that if it dies here, many organizations that have even private health insurance, you go to exclusion criteria, mental health. Even the national health insurance itself, for most primary care and all that, they will tell you that mental health issues are exclusion criteria.
What are we doing about our herbalists and traditionalists? Whether we like it or not, friends and relatives will take their people who suffer from dementia to these people. So what are we doing with them? Are we going to involve them in this policy making?
Ghana is aging, and as you know, the world is aging. our older population is growing steadily, and with it, the number of our mothers, fathers, grandparents, and elders living with dementia cannot be overlooked. Yet for too many families, dementia remains a condition without a name. It's misunderstood, shrouded in stigma, and too often attributed to causes that lead families away from care. A person living with dementia in Ghana and the family that loves them currently have no clear defined pathway. That is a gap this partnership seeks to close. And it is why this workshop is not a conference at which you merely and typically listen. It's a workshop at which we shall together build. What we agree in this room can become the foundation of how Ghana cares for her citizens living with dementia or any other neurocognitive disorder for generations to come.
Most of the time when we mention dementia, it's kind of out of reach for us. It is not a common problem that we know of. But now it's catching up with us. For example, the statistics that were shared tells us that dementia has come to stay. But the sad aspect of this is that are we aware? Do we know? Do we have the tools to manage it? That's the problem that we are struggling with now. Now, if you look at the way we have been looking at dementia, spiritual, religious, also juxtaposing on this, it's a huge challenge. And what do we do even when people have the disease? Or what do we even do to even pick that people are having the disease? So this program is so important to bring all stakeholders together, the policymakers, the traditional leaders, the religious body, and the service delivery, and the researchers, so that all of us together can craft a common pathway, one in identifying the cases, letting people know they really exist, and that it's not that people are suffering spiritual attacks, and also how and what they should do when they have such problem.
I believe that as it has begun, if you increase the awareness creation, especially to community members, I think it will go a long way to reduce the stigma that is related to dementia. And again, I believe that as a health service, because of the low awareness, even in the health insurance, there is no package for its management. And I believe that as we create awareness and increase this awareness, we should also advocate for its inclusion on the health insurance benefit package, so that people living with dementia can also have, a way of getting their health bills reduced or catered for. And this will go a long way to reduce the burden on caregivers.
Last year we had people who are living with dementia. They shared their stories, they shared their experiences, and then the caregivers was also part. This year we have more policymakers, we have more stakeholders, we have specialists, we have nurses, we have psychiatric nurses, which is so good because they all come together to help in the care of dementia. The survey that we have taken, that is the pathway for dementia, or talks about the dementia pathway, which is the same as the patient navigation care, should be more emphasized, and they should focus on that, because when someone is diagnosed at the CHIPS compound, the person needs a navigation way to the tertiary education or tertiary treatment, so that he or she can be seen. So what I will entreat them to do next time, to incorporate patient navigation into the care system of dementia, so that at the end of the day we will have a comprehensive or a holistic assessment for every patient living with dementia?
So far, it's been very insightful. I like the fact that the program cuts across all the needs of the aging population. So although there's a focus on dementia, there's also emphasis on caregivers.
There were a lot of issues we were not privy to, and we didn't know how bad it has been. But with the presentations done so far, we've now realized that we have an issue, especially when it comes to aging and dementia.
Basically, having listened to Professor Macaulay talking about the fact that they have initiated certain activity to ensure that a bill is being passed for aging, to actually look at this, I think is in the right direction. What I was expecting to hear that I think they have not touched on so far is about brain health and brain economy. I believe in having that brain skills, that brain health and mental health being fused together to generate an investment case. If we are training people to build that kind of their cognitive skills, their ability skills, and reasoning skills, you get to old age and you not have the issues of forgetfulness because you have been groomed to ensure that you always put in activities that will put your brain health intact.
It looks as if everything that needs to be heard has been said, especially when the dementia is concerned. How family sees it, how churches actually see it, how the community also see what dementia actually is. And the step to be taken anytime a loved one has dementia. As time goes on, I believe that we'll all be educated more on the need to understand dementia very well. Because we usually term it to be witchcraft, but it is not, it's part of aging.
There is something called dementia. As we are able to come to terms with what it is, it will help us salvage the situation where we lynch people and name call them, we call people witches and all of that. And I believe God will help this whole team and the good work they are doing to become something that will create the awareness across Ghana that dementia is real. It comes up when people are growing older. You see, watch out for it, and then let's save our older folk.
So the Center for Aging Studies was set up really to provide a more interdisciplinary approach to aging. Why? One, because aging, we all age. The trends of aging in Ghana has more than tripled over the last several years. And in fact, right now, it's estimated between 8 to 10% of the Asian population over the age of 60, 65. It's very important because we are aging more. In fact, if you look at the world aging trends, Ghana comes around us or the fastest. So it's important we take a serious view about aging for a number of reasons. One, to educate our population about it, but also to ensure that the aged receive adequate care. I really want this not to be a one-off thing, but something that could be collaborative in the longer term. As the center and the director will tell you, we're looking for collaboration, not coming with a begging bowl, but as equal partners in advancing. In fact, we also have the African story to tell about aging.
Dr. Dodu, kudos to you for bringing this to our doorsteps, and more grease to your elbows, because we want to be working even with you on such tangents and to make sure that the issue of dementia becomes something that even policy imbibes into its folds and makes life easier for individuals who are affected by dementia.
I believe that the participants who attended to this meeting through the engagements, the discussions, have learned a lot. It has opened our eyes to new ways of thinking about dementia, the importance of doing public sensitization and education on dementia, and also fighting against the stigma that surrounds, aging, and then especially older persons who are aging with some kind of health conditions. And so that's what we have done today. We have tasked ourselves that this will not be a 9-day wonder. It will not be just an ordinary conference and workshop we attend, and then at the end of the day, you go away and that's it. But rather be something big that is beginning small, but the steps we will take can bring us very far. And that's what today our workshop has actually focused on.
And so the recommendations from this workshop should provide us a practical roadmap for strengthening dementia care in Ghana. The Ministry of Health looks forward to engaging with the outcomes as we continue to shape policies and programs that respond to the changing health needs of our population.
Based on funding from the Research Investment Funding, School of Human and Health Sciences, University of Huddersfield, we've also brought together stakeholders today to be able to co-create or co-develop a dementia referral care pathway for Ghana. We've had enormous support from the Ministry of Health Ghana. We've had support from their various agencies, NGOs, and also our partner institutions. It is really important at this point to acknowledge the University of Huddersfield in this whole funding and also providing us with support through academics who are supporting on this project. We also thank Komfanochi Teaching Hospital, specifically Dr. John Paul Omoyeni, who is the head of the psychiatric unit. We thank Dr. Nana Kwame Eyisibuateng, who is the director of the Kwame Nkrumah University of Science and Technology Hospital, who is a key member of this project. We thank Joshua Ochre, who is a PhD student at the University of Huddersfield, but based in Ghana, working on a longitudinal study, which is the Ghana arm. I also thank Professor Warren Peter Gillibrand, who is the acting dean of the School of Human and Health Sciences, University of Huddersfield. Thanking you for your leadership, and of course through your administration and all that, we've been able to get this funding for this project. And you are a project team member yourself, so thank you so much for your enormous support. We also thank Dr. Biba Simkada, who is an associate professor at the University of Huddersfield.
Professor Padam Simkada, Dean of Global Impact and Research, University of Chester, UK.
We thank Dr. Datel Norman, who is a geriatric consultant or consultant geriatrician, Harrogate NHS UK. We also thank Douglas Eninopoku, based at the KNUST Hospital, for his enormous support. Reverend Professor Joseph Osafodu, who is the director of the Center for Aging Studies, University of Ghana. Dr. Delali Ajua Dovier for their great support. And then Samuel Salu. These are the project members. We really thank them for their support. We also thank all our guest speakers, starting from those in Accra, Professor Christopher Charles Mate Colley. We also thank Professor Achi Isuman. We thank the Ashanti Regional Director of Health, Dr. Fred Adomako-Boateng, who is a project team member himself. And then we also thank Professor Veronica Millicent Jomeku, who is the Dean of the School of Nursing and Midwifery, Kwame Nkrumah University of Science and Technology. And then, of course, the incoming Vice Chancellor for Kwame Nkrumah University of Science and Technology, Professor Christian Ejari, who is currently the outgoing Provost of the College of Health Sciences.
Mrs. Evelyn Amwakon, Deputy Director of Nursing and Midwifery at the Ministry of Health, speaking on behalf of Dr. Hafiz Adam Taher, Director of Technical Coordination at the Ministry of Health.
I also want to thank the media who have taken a keen interest in this whole program, because dementia is a big thing, but of course it is masked, it is underreported. So when they heard about this project, majority of them came to cover it. I want to give it a shout to Joy News. I want to give a shout to TV3. I want to give a special shout to Ahimfie FM, Dr. Nana Kojo Jantwa, for bringing us on the morning show to do an extensive education. That's really appreciated. We thank the University Relations Office, KNUST. We also thank all participants for the enormous expertise you brought on board to make sure that this co-creation workshop is a success.
And I believe that the kind of insights that they have shared today in particular is something that is going to help improve dementia care in Ghana. Through this engagement, we have come to understand the problem that exists in terms of dementia care, where almost everybody was beating the same drum, lack of awareness about dementia care, even among healthcare workers, to the extent that even in our DAMs or our health records, there is no diagnosis on dementia in it. And so that actually is a big deal. It's actually a big deal, especially if even at the health facility level, we are not recognizing this condition.
And we hope that we don't end here. We're going to take this further, looking forward to collaborating with the ministry and every other one involved, all the NGOs and the care homes that send their representatives, the academics, family caregivers, everyone really. We want to collaborate, build a bigger collaboration and be able to move a step further after this dementia referral care pathway. We are looking forward to collaboratively developing a dementia policy for Ghana, stigma reduction campaigns for Ghana, and then of course peer support or network for family caregivers who are at the forefront of quote and unquote this war. Thank you so much, and privileged to be your principal investigator. Stay blessed.